Afternoon, colleagues. Thank you so much for joining us in today's session on behavioral change. I know that it's a bit late in the day, and I really hope this session is going to be fantastic and you're going to enjoy it because we've got lovely presenters lined up for you. My name is Sifiso Dlamini. I'm a doctoral researcher from Loughborough University in the UK. And today we have Maddie, who is also a doctoral researcher, who's going to be the timekeeper for the session. So please feel free to ask any questions or comments after each of the presenters have shared their presentations. So today's presenters, we have Mita, Sirait, who's gonna be speaking about the complexities of safe child feces and diaper disposal behavior change in rural and urban and rural Indonesia. And our second speaker will be David Galibourg from WEDC at Loughborough University, who will be sharing a presentation on safe washing with wastewater-irrigated vegetables, motivating behavior change among street food vendors in Accra, Ghana. Our third presenter will be Claire MacLeod from the London School of Hygiene and Tropical Medicine, who will be presenting on household behavior change interventions for sanitation and hygiene in urban settings, a scoping review. And the last presenter will be Kondwani Luwe. Unfortunately, he's not here and he could not make it, but he has a colleague that will be covering his presentation on perceived facilitators and barriers to hand washing behavior among mothers and their guardian in Malawi. So please give me a round of applause for our first speaker, Mita.
Thank you. Hi everyone. Thank you for coming here. So I will introduce myself. My name is Mita Sirait. I'm from Wahana, Visi, Indonesia. I'm a specialist. Wahana, Visi, Indonesia is the local partner of Vision. If you see the logo there, it's similar. So I'll be talking about complexities of safe child faeces and diaper disposal, behavior change in urban and rural Indonesia. English is my third language, so please bear with my accent. If you're not capturing clearly, you can come for later and asking questions about it. Okay, I will start with the first slide. Okay, this one is here. Okay. Yeah. Sorry, technical issue. Okay, safe child faeces and diaper disposal, we call it SCFDD. We make it short, but still a bit complicated to say. So consists of multiple components. So first, disposing of child faeces from the diapers into latrines, and then cleaning and folding the clean or the used diaper, and then moving it or disposing of the diaper waste into a separate trash bin. So this is a complex behavior. So that makes sense that 60% of the waste found in Surabaya River is single-use diaper, and 30% of households, either in rural and urban Indonesia, they just litter or throw away the diaper without cleaning it. And then based on our research or our monitoring in our program, we found that in 15 cities or agencies in Indonesia, 87% of the family, they don't dispose the child faeces properly. So that is the background that we found in our program. So for the reason we develop a research, we are trying to investigate what is the determinant of the behavior and whether, because it's a complex behavior, whether the determinant is the same from the one is complete behavior or of STFDD, or single behavior also has a different determinant. So we are investigating the behavior, the determinant. So the research question is, what are the determinants of STFDD behavior change as a whole and each component among mothers or caregivers of children before toilet training age in Sekarang Regency and Surabaya City in Indonesia. We do a quantitative survey and qualitative focus group discussion, and then with a total of 508 respondents from Sekadau, rural Sekadau, and then urban Surabaya City. And then we developed questions, 57 questions with 4-point Likert scale based on health belief model and theory of plant behavior. And we did exploratory factor analysis and stepwise multiple linear regression to test the significance. So what are the findings? We found that parental ignorance or caregivers who did not do anything about it, I mean, just did not do anything, is determined by the disease susceptibility. Sorry for that. So they perceive that child faeces will not cause disease. Child faeces is not harming, and child sickness is not a serious thing. It's normal for children to have a sickness. So they just don't do anything about the baby faeces and then diaper. So in other context or not, for the people who are doing the complete SCFDD, we found that it was determined also by health benefits, the perception of the health benefits for children, and injunctive social norms enforced by the health workers and faith and community leaders. And then the determinant of disposing child faeces from diaper into latrines also perceive hygiene environmental risk, although also influenced by moral beliefs and shame. So those people who are disposing the child faeces and then to the latrine has a more influence or more determined by the hygiene, the perception about hygiene or environmental risk. While cleaning and folding the diaper, so it will not be tampered by the animals or pollute the environment. It's influenced by the social norms because other people do the same, and to perceive hygiene or environmental advantage and health risk also. And then the last is about segregation of single-use diaper waste. This is the third breakdown behavior. Is influenced by the perception about hygiene and environmental benefit and injunctive social norms. Yeah. So the discussion here
So sorry. Are you on presenter mode? Yeah, it is on presenter.
Yeah. Sorry, the presentation is not really projecting, so it hasn't been moving. Yeah. So what she's seeing on the screen is not being projected on the bigger screen. Yeah. Yeah. So I think we can just continue.
I'm having trouble changing the slides. They're not moving on the screen. We are in WEDC. Right? Sorry, someone should be having a minute.
Oh yeah, it's okay. So yeah. Okay. So yeah. Okay, sorry for the technical issue. Actually, this is not the correct or the latest
Sorry.
Sorry. Well, yeah, so this is the findings. I hope you can read quickly because
No, it's fine.
yeah, that is a mark
Still
from there.
have time.
Yeah, so if we break down the component of the behavior, there are three behaviors. In the first behaviors, there are the determinants are more different than the complex or complete behavior. The interesting ones is that when you these two, the STPD as a complete behavior, the perceived health benefits for children is the biggest or the significant determinant. However, the person who are not doing anything, the opposite one, also has the perceived health risk as the significant determinant. So in the way, it's because maybe our assumption is that people who think that baby faces are not harmful, maybe that's the driver of this perception. Okay, so the conclusion, I will come up to the conclusions. The conclusion is this research explored the potential of analyzing a complex behavior by breaking down the behavior into simpler components for single behavior. And then analyze each component of behavior separately to inform behavior change intervention design. So that's my presentation. Thank you for listening. I'm sorry for all the technical issues here. Thank you.
Yeah. Sorry, sorry about that. Thank you so much for your very insightful presentation. Though we couldn't follow on the screen, but you were very clear. Thank you very much. Yeah, we are open for any questions, comments on what you heard from Mita. Does anyone have any questions, comments? Yes, sir.
Yeah, I'll speak loudly. I'm curious about the implications for other countries and other contexts. I know Mita works in Indonesia, but does she have any indication of are these similar issues in other parts of Asia or in other places, or have you seen research from other parts of the world? Just the context in other places.
Oh, yes. We found this behavior is a big issue in Asia, Southeast Asia mostly. And there is no, up to now, there is no significant intervention in place, including in the government. Still is a big issue because this is related also to open defecation. In our context or in Asia context, when the baby diaper is not properly managed, it will be, how do you say, dragged by animals and scattered around with the faces of the baby. The thing is, most of the people in Asia think that baby faces is not harmful for the environment, also for the family, also for the healthiness of the people. Why? Because it's a baby. Baby are innocent, and baby are not, the faces of the baby are also innocent. So yeah, it's still a big issue in Asia, I would say. Thank you.
Thank you. Any other question?
Just you spoke about the social norms and also the awareness. So you explained both our problem. On which one would you focus more or first?
Yeah, for the intervention, this is why we separate it, we break this down. It's because of the intervention is a bit complicated. So we go through three things like the normal in what is the sanitation approach. We do advocacy of course to the government level because they do nothing about this. And then for the community, we try to work closer with the health workers also, because the health workers also say they don't have anything about this issue. I mean, there is no guidelines, there is nothing about baby faces management. And we work with the community like health volunteers to do monitoring, home monitoring whenever they have time. I mean, they have a schedule to do monitoring in the community. They also ask questions about this behavior. So there's more up to now.
Yeah. Thank you so much for the questions. I will call upon our next speaker, which is David Galibourg.
Hello, good afternoon, everyone. Looks like it's all right. I have more than me. I'm David Galibourg. I'm a PhD student at WEDC, Loughborough, and I'm working on case studies in Accra, Ghana, where I'm working with the National Water Management Institute, and in South Africa with the University of KwaZulu-Natal. And today I will present our research on the safe washing of wastewater-irrigated vegetables, how to motivate behavior change among street food vendors in Accra, Ghana. Same problem.
Yeah.
Sure. so sorry.
Sorry about that.
Just
Yeah, that's. What he does this time. Yeah, sure.
Yeah.
Which one?
It's not there.
Okay, over here.
I don't know if your colleague will put it in the folder.
Yeah.
Yes, it's there.
Yes.
The first thing. I think it was the right one. The other ones are not better. Yes, can do that.
Present over here.
Yeah. And then.
Some exit this one. Supposed to share it. You're able to see there.
Okay.
But now see it doesn't change.
Yeah.
Because imagine this one.
Okay.
Because you have to go over here and like select this. Okay.
Okay, good.
Okay.
So you probably know this diagram of the sanitation value chain, which says that to have safely managed sanitation, you need to have safe containment, safe emptying, safe transport, safe treatment, and safe reuse and disposal. In many cases, on the ground, we notice that there is leaks of septic tanks in the rivers, that the emptiers cannot go as far as the treatment plant, so they will discharge in the river. That maybe the treatment plant is not going to be fully operational, and the effluent are going to be discharged without being fully treated. Or in some cases, farmers may ask pit emptiers if they can empty the fecal sludge directly in their field, or they are going to break pipes of wastewater to fertilize or irrigate their fields. The result is that often farmers use water that used to be fresh water and is now contaminated with fecal pathogens, and use it to irrigate their crops. The pathogens are transferred to the crops, and we find them on the markets and ultimately in street food or in the lettuces, vegetables that people are going to consume raw. It is estimated that about 800 million people live in cities where the food is contaminated because of being irrigated with wastewater primarily. It is also the case in Accra, where this is a drainage canal that is supposed to receive rainwater. And as you can see, it's not exactly rainwater flowing there. You have here wastewater from the nearby houses. Here you have cows whose feces go in the river. And what you will see is that farmers then pump this water to irrigate the lettuces that end up in people's lunch. So to mitigate this situation, the WHO, since 2006, proposed a multiple layer approach, saying that if the sanitation sector is not fully operational, maybe stakeholders, meaning farmers, vegetable traders, street food vendors, and consumers, can adopt safe practices whose combination is going to mitigate the risk and reduce it to an acceptable level. Except this has been around for almost 20 years now, and uptake has been very limited. So to look why uptake is not better, we are using a behavioral change framework, which is the COMBI model, which basically says that for stakeholders to perform a new behavior, they need to have the capability, the opportunity, and the motivation to adopt that behavior. Today, we're going to focus on those components, the motivation component, and on the end of the value chain, meaning the street food vendors. So how street food vendors wash lettuce in Ghana they use a 3-steps method. They're going to first use a bowl of plain water and wash the lettuce to get rid of the dust and of the dirt. Second time, they're going to soak it in a basin or bowl of water, to which they will have added a little pinch of salt. And then they will rinse it in a bowl of plain water. The problem is that even though they use salt to get rid of the germs, at the concentration of salt that they are using, there is not much happening. So what we are trying to explore is how we could convince the street food vendors to use potassium permanganate. So potassium permanganate is that deep dark purple powder. It's an oxidizer that is used in wastewater treatment and also for skin disease and feminine hygiene. It's also available in pills and tablets. And if you mix it in water, it makes the water purple, and you can wash vegetables in it. It's going to eliminate the bacteria and some pathogens, most of the pathogens. So what would motivate street food vendors to replace salt with potassium permanganate when washing vegetables? What's your guess? When I ask my colleagues, the most frequent options are maybe raising awareness through education, finding the right incentives, or maybe finding the right type of sanctions to punish those who are still using salt. To explore that, we're using the Wahana's behavior change method. Wahana stands for risk, attitude, norms, ability, and self-regulations. So those are 5 categories of factors, and we're going to see later that they are divided in subcategories. And the way that method works is building on the interviews and the formative studies. We can design a survey, which in our case we conducted with 250 street food vendors, and then conduct an analysis of doers versus non-doers of the behavior. In our case, no street food vendors, or barely any, are actually using potassium permanganate. So it would be more adequate to speak about people who are willing to adopt versus people who are not willing to adopt. So this is the results of that survey. What you see in light blue is the answers of the people who are willing to switch from salt to using potassium permanganate. In pink, that's those who are not willing to change. And in green, it's the difference between the two groups. And so what that method says is that the parameters or the factors that have the largest contrast, the largest difference, are those that should be leveraged to convert the non-adopters into adopters. In general, we consider that any factor that is beyond 10% is relevant, but in our case, we have so much contrast, we are going to focus on those who are above 30%. And you can see up there the 5 categories, and here the subcategories. So if we focus on the most important one, it's others' approval. This means that when we ask the same questions to the whole population, a little above the doers, a little 80% of people who were willing to switch for behavior were persuaded that their peers would approve of their new behavior, while among non-doers or non-adopters, it was a much lower ratio. The same was true for the personal importance. How important is it to you to wash your vegetables safely? And for the 3 other factors, it was more relevant on their confidence they would be able to perform the behavior, even if they had to interrupt it for some time and to recover from it. So the first category of factors was the social norms. So others' approval is also called injunctive norms. And if we look at the Wahana's method, they say if you have this, if the parameter that offers the greatest contrast is this one, then you can use this type of behavior change technique in that case, informing the street food vendors of others' approval. In the case of personal importance, we could think that maybe it's the time to use education and convince them that it's important for health benefits or these reasons. But really what it is that it should be important to them to be in the right team, to be among the street food vendors that perform the right behavior. And that can be done by providing a positive group identity and by prompting identification as a role model, which means that if their peers come to them and saying, why do you do things differently, instead of feeling or perceiving themselves out as outliers, they should perceive themselves as role model and actually explain. For these three later factors, actually, often the recommended behavior change technique is a bit different, but in our case, because that's not a behavior that is actually in place, but one that is supposed to happen later, we find that what is important is also to ensure that they have the opportunity and the capability of performing the right behavior. And in our case, it's making sure that the potassium permanganate is readily available, accessible, and affordable, and it's generally found in pharmacies. So the take-home points is that in order to promote a new behavior, we need to make it easier and more attractive, that the factors that were most relevant for street food vendors in Accra were to make sure that they have others' approval and to strengthen their perception of the personal importance. That comes in contrast of what is often thought, that education is the primary factor, or maybe cost. As we could see on the previous slides, education would be important, but would not be enough, because whether they want to do it or not, street food vendors seem to already be aware of their exposure to the risk, the vulnerability, and the severity. And we also had questions about the cost, and the contrast between the two groups was 24%. They were saying we were willing to pay much more than the actual cost. And the last one means that when we design this kind of intervention, it's better to avoid this thing, which means it seemed like a good idea at the time, which is often how it looks like interventions have been designed. Thank you.
Thank you so much, David, for that comprehensive presentation. So I will be taking questions or comments for this particular presentation.
Hi, I wanted to ask, I saw that you mentioned the Combi framework in the beginning, but then you ended up using the RANAS model for the survey. So I was wondering if you're planning to go back and use the Combi for the intervention design, and if the RANAS model was only for the survey?
So the Combi model is a framework, and it's very wide-ranging. And the RANAS method both overlap quite a bit. And so the RANAS method has been developed for development project and WASH project. And very pragmatically, I had the training for the RANAS method before I had the training for the Combi model. So when I was in the field, I went with that one. But basically, it's not so much about the Combi model there. It would be about the behavior change wheel. And it comes back to the same at the end. The big difference is that the behavior change wheel and the Combi framework build on 11 different theories. This one focused on 2 or 3. But and also the number of behavior change techniques, they have like 30 something when the behavior change will have 83. But it overlaps a lot, and there is nothing that prevents me now from using the behavior change wheel or the behavior change technique recommended by them to act on these results.
Hi, thanks. I have 2 questions. The first is, does the potassium permanganate leave any purple color residue on something like lettuce?
Not on the lettuce, because the contact time would be like 5 to 10 minutes. It could leave traces on the hand if they are keeping their hand in the water all day long. And I asked some people, so the countries neighboring Ghana use both chlorine or potassium permanganate. And when I asked them, are they not disturbed by the purple color, they say we prefer the purple color rather than the smell of the chlorine. So they seem to be fine with that. So no color on the lettuce, but possibly color on the hands of the person who's going to spend the day washing it.
Okay, thanks. And then my second question is, for others' approval, you mentioned peers. Were you able to explore more who those peers were, or when it came to others' approval, was there, did that come into the customer base at all?
Yes, so when I said peers, the question was actually asking people about their colleagues, street food vendors, and about their customers. Because the competition between them is such that obviously they don't want to have their disapproval of their customers, but they also don't want all the street food vendors to say, don't go to this one because he's doing this weird thing.
Thank you so much, colleagues, for those questions. We're running short of time, but our presenters will be available after the session for any further questions that you might have. Thank you. We will have our next presenter, Clara. If you could just please come.
Is it these teal ones? We get a bit light before we start.
Yeah.
Hi everyone, my name is Clara MacLeod. I'm from the London School of Hygiene and Tropical Medicine, and today I'm presenting on a scoping review on household behavior change interventions to improve sanitation and hygiene practices in urban settings. And this was done in collaboration with colleagues from the London School of Hygiene and Tropical Medicine, Catherine Davies, Oliver Cumming and Robert Drivelbis, and Mwamba Mwingi and Janala Chikungu from the Center for Infectious Disease Research in Zambia. So first, for some background, behavioral frameworks and theories have been used in public health as well as in WASH, and these have been used to develop and design interventions as well as understand various factors that drive a certain behavior. And as was mentioned in the previous presentation, here's the COMP framework, which suggests that motivation, capability, and opportunity are needed to for a certain behavior to happen. So two previous systematic reviews have been done, and these looked at behavior change approaches for water, sanitation, and hygiene. But the two systematic reviews did not disaggregate results for urban and rural areas, and these were both undertaken over 5 years ago. So very specifically, the evidence on which behavior change interventions are effective at improving sanitation and hygiene practices in urban settings is unclear. And so this systematic or scoping review aimed to fill that gap. And the aim of this review was to identify and summarize these interventions on household level sanitation and hygiene practices within urban settings. The objectives were first to identify behavior change intervention components from each study and map them to the COMB framework intervention functions, which I'll go into more detail in the next few slides. Second, summarize intervention effectiveness, and third, identify evidence gaps for future research. And we followed the 5-step ARC-C and O'Malley framework for scoping reviews, and I'll go into these 5 steps in the next slides. So first, our research question is, broadly, what behavior change interventions targeting household level sanitation and hygiene practices have been implemented in urban areas? And this question is just very broad to just understand what has been published and what is out there. Second, we searched 5 databases and 1 gray literature using relevant search terms. We also hand searched reference lists of included studies and other systematic or scoping reviews. And we restricted the date from January 1st, 1990 to November 20th, 2023, when we conducted the searches. We included various study designs as long as they had a control. We relied on author-reported definitions of urban settings, and the intervention could be delivered either at the individual household or community level, as long as it targeted household level behavior change interventions for sanitation and hygiene. So for step 4, we extracted data on study characteristics, on the interventions, outcomes, and results. And we specifically charted all of the different intervention components to the 9 intervention functions of the COMBI framework. These include education, persuasion, incentivization, coercion, training, restriction, environmental restructuring, modeling, and enablement. And this allowed us to systematically map all of the different intervention components. And then finally, we reported the measure of effect, 95% confidence interval and p-values for all relevant outcomes. We summarized the different results by sanitation and hygiene. And we did not conduct a meta-analysis due to the heterogeneity of outcomes. And this is our Prisma flowchart showing all of the different searches and screening. And in total, we identified 13 studies which met all of our inclusion criteria. And now to go over some study characteristics, first in terms of study settings. Most studies were implemented in urban informal settlements, primarily in South Asia and Sub-Saharan Africa. As you can see on the graph on the left, there are 3 studies implemented in Bangladesh, 3 in Pakistan, and then 1 in each of the other countries. And then on the right, this shows the breakdown of urban settings. And again, this is primarily in urban informal settlements, with 3 studies in peri-urban areas. In terms of the different intervention functions, so most were implemented in combination with at least 1 other intervention function, and environmental restructuring featured most frequently. So you can see on the left, this is a heat map of the different intervention functions and how often they were implemented with one another. So environmental restructuring, education and persuasion, and education and modeling featured the most frequently together, as well as environmental structuring and persuasion. Only 2 intervention functions were implemented alone, but just looking at the frequency, environmental restructuring featured 10 times, followed by education and persuasion. So there's definitely common themes there in terms of the intervention functions. In terms of outcomes, we identified 36 outcomes amongst the 13 included studies, and we grouped these in terms of sanitation, hand hygiene, and food hygiene. So in terms of sanitation, these were grouped into improved latrine quality. So this could be latrine privacy or latrine cleanliness, safe child feces disposal. For hand hygiene, this includes hand washing with soap, or the presence of soap and water at the hand washing facility, which is typically used as a proxy measure for hand washing with soap. And then for food hygiene, there are only 2 outcomes in total, and these are safe food storage and safe child feeding. Now, in terms of results, so this shows the total number of outcomes per outcome category, and green shading indicates a positive effect on the outcome, and yellow shading indicates no effect on the outcome. So you can see first, in terms of improved latrine quality, there were 13 outcomes, and all of these were positive. Only 1 outcome for safe child feces disposal, 14 for hand washing with soap, 6 for presence of soap and water, and again, 1 for safe child feeding, and 1 for safe food storage. So back to sanitation. Interventions improved latrine quality, but not safe child feces disposal. In terms of hand hygiene, interventions most increased hand washing with soap and the presence of soap and water at the hand washing facility, but not always. And then finally, for food hygiene, there is limited and mixed evidence on these outcomes. So a bit more on the results. What we found is that outcome definitions varied greatly across all of the included studies. So for example, latrine quality was measured as 2 different dimensions, and this could include latrine cleanliness or latrine privacy. Hand washing with soap was also measured differently in each study and at different key moments. So it could be before food preparation or after using the toilet. Measurement methods for the different outcomes also varied across the study. So hand washing with soap was usually measured via structured observation, sometimes self-reported behavior, or proxy measure, so presence of soap and water at the hand washing facility. And each comes with pros and cons. And sanitation outcomes relied on both fieldworker observations and self-reporting behavior. And then finally, most outcomes were measured between 6 to 12 months post-intervention. So it's unclear whether interventions are effective over the long term, so 2 to 5 years after the intervention. And so 2 big takeaways. So most studies included a limited number of intervention functions, and they were implemented at the household level. So no studies looked at financial incentives for sanitation and hygiene in urban settings, which warrants further exploration, as well as looking at nudges and environmental cues. Also, all of the interventions were implemented at the household level. So there's also an opportunity to look at interventions implemented at the community level. And another main takeaway is that the studies included a very narrow range of outcomes, especially for sanitation, which was improved latrine quality. And a lot of those sanitation outcomes were related to sanitation cleaning, which is important for sanitation, but more broadly, there are also opportunities to look at sanitation adoption. And finally, no studies looked at fecal sludge management or larger scale interventions. And finally, no studies accounted for water supply, which is required for hand washing with soap as well as for sanitation. And finally, to conclude, behavior change interventions are an important component of sanitation and hygiene interventions, and generally improved latrine quality and hand washing with soap. But there are opportunities to evaluate more ambitious sanitation and hygiene interventions, specifically in urban settings. There's a preprint or a QR code for the preprint, but also to say thank you to UKAID that funded this research. Thank you.
Questions? Any questions on the presentation? Thank you so much for the presentation.
So one of the main factors was the environmental restructuring. Did you see if it was more the physical or social?
It was more the physical.
So it was building trees.
It was more on the hand washing side. Okay. So the provision of a hand washing facility. So usually it was the tippy top, getting the stuff in.
Okay.
Any more questions, colleagues?
Thank you. I wondered what counted as a positive outcome.
It was usually the measure of effect and then p-value.
Okay.
So yeah, we just extracted all of that data for each outcome.
Any more questions? Okay. I think I've got a question. I just wanted to know more about what would you consider some of the fundamental behavioral determinants from your research? I think our first presenter spoke a lot about that, and yeah, so I'm just intrigued that's in the presentation.
Yeah, we didn't look specifically at determinants. We really just looked at the behavior change intervention that was implemented in that setting. And then
thank you very much.
Thank you.
We will now call upon our last speaker. Unfortunately, the speaker that we were supposed to have couldn't make it, so he arranged for a colleague to present on their behalf. So if you could just introduce yourself.
Sure.
Yeah.
Cool. Thanks, everyone. I'm Robert Dragovis from the London School of Hygiene and Tropical Medicine, filling in for Kondwani Luwe. He saw the schedule and realized he would be the last presenter standing between a group of people and a happy hour, so decided not to come, sent me in his place. So project all your rage here. No, there were visa issues, but happy to jump in for him. This is our talk about his work on perceived facilitators and barriers to hand-washing behavior among new mothers and their guardians in Malawi. This was a part of a larger research partnership between the University of Strathclyde, London School of Hygiene and Tropical Medicine, and our colleagues at the Malawi University of Business and Applied Sciences, or MUBAS, and funded as part of a larger platform of research by the Reckitt Global Hygiene Institute. So just for some background here, we know global neonatal deaths are still persistent. There were about 2.5 per year. Maternal mortality, around 287 deaths per year, and over half of these deaths are occurring in sub-Saharan Africa. Malawi, specifically, the neonatal mortality rate there is about 19 deaths per 1,000 live births, and maternal mortality ratio of about 381 deaths per 100,000 live births, which are both relatively high compared to other countries. Infection, specifically infection attributed to poor hygiene, contributes to around 50 or 10% of this mortality burden specifically. And this is also infections that are occurring during a very, very narrow window in that immediate post-birth period. And WHO, part of their standard guidelines for controlling this kind of infection during the immediate postnatal period, really recommend focusing on hand washing with soap at critical times. Now, what the problem here that we're kind of investigating a little bit more is we wanted to take a closer look at the role of patient guardians. Now, patient guardians end up playing a really pivotal role in the health system and healthcare delivery in Africa, and particularly in Malawi. So carers, particularly in neonatal wards, these are kind of guardians, they're family members, extended friends, someone within their kind of larger social network who cares for the mother after giving birth at the healthcare facility. Their roles vary, but they often are doing things that in a kind of more traditional high-income setting, we would consider healthcare delivery. They're doing things like administering drugs, cleaning wounds, cleaning sutures, dressing those wounds. But they're also responsible for cooking food, serving it to the patient, or in this particular case, the new mother, doing laundry, so kind of really running the gamut between kind of an orderly physician assistant, just doing a whole lot of stuff. But I don't know about a lot of you, but I wouldn't want my mother doing many of these things. But their duties really require hygiene practices to prevent potential infections, particularly for the new mother and their child. Interventions that we have around hand washing with soap, particularly targeting this environment, however, often focus on the new mother or the formal healthcare providers, and they're entirely missing these guardians, these people who are really responsible for the frontline delivery of a lot of this healthcare. Important to note that a lot of this care extends not just to the facility, but also to the home environment. These are people that often bring the mother home, and they're responsible for support during those first few days in the home environment. So part of this, if you'd like, we've recently published a study by Mindy Panulo and colleagues looking at the environmental conditions in the guardian waiting shelters. This is where these guardians kind of go. They're dormitory style conditions. They are, they're pretty abysmal, but you can read about that in the paper. We're going to talk about what's going on in the healthcare facility. And what we wanted to do was understand hand washing practices of new mothers and their guardians, specifically at the healthcare facilities and in the immediate household environment, and to identify the determinants of hand washing practices among new mothers and their guardians, both at the facility and the home environment. Spoiler alert, we also used the COM-B framework. So get to jump through those slides. So what did we do? So this was a cross-sectional exploratory study. We went to 2 facilities that were part of our original assessment. And in both of these facilities, we did observations and interviews, both in the postnatal care wards and at the household environment. Looking at both new mothers and their dedicated guardians. We did this in one facility that was managed by a non-governmental organization and one public facility. So we completed these observations at the healthcare facility. We did wash checklist at both environments, and then direct interviews. So talk through some of the results. So what do we find? So looking specifically at the government-run postnatal care ward, water was piped onto premises. They had sanitation facilities that were available for the guardians and the new mothers, specifically 3 flush pour latrines. 6 sinks were available within the postnatal care ward where these mothers were. Absolutely no soap available anywhere for anybody to use. At the private postnatal care ward, again, water piped onto facilities, flush pour latrines, only 2 sinks this time, but our commonality here, no soap available for anyone to use within this facility. At the household level, about 30% of the households we went to had water piped onto premises. 75% of the households had a pit latrine or a better, but only 10% of those households actually had a dedicated hand washing location. This was either a sink or a standpipe, and only 1 household had soap available in it at the time of the observations. So here's some images. These were the sinks that were in the wards, and then one of the household latrines. So. Okay, what do we see? This is a big table to show you a lot of zeros. We saw effectively no hand washing with soap at the postnatal care wards by new mothers or their guardians, which makes sense. There was no soap in the facility. So unless they could magically conjure that at the moment they needed it, we would expect that to be pretty low. What we have here is a table of hand rinsing that we saw. So when the new mother or their guardian rinsed their hands with water, and we do see relatively low rates here. So the number of opportunities among new mothers was actually incredibly low, much lower than we were anticipating. But that also makes sense. These mothers have literally just given birth within the last few hours. They're pretty tired and pretty worn out. So not a lot of running around to go wash their hands. I think more important is the number of hand washing opportunities we saw among guardians. So really we saw relatively low hand rinsing rates among these guardians. When it was done, it was often done using kind of bottles, jugs. No one was rinsing in these sinks that were available in these facilities, really making use of kind of improvisational hand hygiene facilities. Similar at the home, surprise, hand washing with soap, not done during any of these observations. In this period, we did note mothers were much more active, but the guardians were still involved in kind of household management in care at the household level. It wasn't like these were just, their roles were isolated just to the facility. But baby care activities, so a lot of this contact with new mothers, were really integrated in some of the household activities. Mothers only we saw kind of visible dirt as a trigger to action. We kind of combining all of the qualitative results here, and I'll just move through the table quite quickly. I won't define any of these, but in terms of capability, so at the postnatal care wards, they have what are called these health talks, and these are important moments where the health facility would engage the new mother on things they were supposed to do in the domestic environment or at there to keep the baby healthy. And a great opportunity to begin hand washing or hygiene education. But these were held very irregularly, and guardians were explicitly not part of that. They were actually not invited to participate and would be done separate from the guardians. So the primary caregivers are the ones that were not there. In terms of opportunity, there's no soap, as particularly in these healthcare facilities. But also to note that there were active barriers put up against the use of some of these facilities. Our qualitative studies found in this facility where we had 6 sinks that the family members were actually told not to use those sinks because they had found that people were going and washing their dishes in those sinks. So the health facility basically didn't allow any of the families to use the sinks because they were using that for purposes that were not intended. If you read our other paper about this, you will know why you're washing their dishes in these sinks, because there's not any running water in the guardian waiting shelters. So big mess here, but a high motivation that everyone had to really make sure that they're kind of protecting the child and the new mother at a particularly vulnerable window. So despite adequate knowledge, compliance with hand hygiene was incredibly low. These include kind of, and other barriers here were access to facilities. We really need more context-specific interventions that are really addressing the determinants here in this kind of ambulatory care, I think is the official definition of where these guardians are in providing care, other things. But importantly, as seems to be the norm, you can read all about this in more detail at your own leisure, not in the 10 minutes I have at the preprint at this QR code. So thank you very much.
Thank you so much for that comprehensive presentation. Do you have any questions?
Thanks so much for presenting. My question is, besides publishing the great work, what is the sort of communication strategy to share these results? Who are you going to share them with?
Yeah, that's a great question. We actually had a stakeholder workshop in June with local NGO partners, the Ministry of Health. Malawi is at a point where they're rewriting their IPC guidelines, and we presented a kind of our comprehensive findings there. So it has been a lot of direct engagement with local stakeholders, both in kind of the NGO space and the government space, and continuing to kind of look for new funding to continue with a lot of this work. We were actually supposed to start testing interventions here, but unfortunately, as we were wrapping this study, there was a massive cholera outbreak in Malawi, and all of these facilities turned into cholera treatment centers. And as you can imagine, there's nobody giving birth, everything changes. So the third phase, the interventional phase, just never actually materialized here. So, but we're continuing with this. So.
Any other questions? Okay.
Thanks. I wondered what the ethical procedures are of doing observations with women who've just given birth, and how long after giving birth you do that sort of data collection.
Yeah, good question. I mean, I've done studies where we observe them giving birth, so this seems
it's obviously quite a
yeah, and you know, I mean, we work with these are all trained enumerators. They're very sensitive. They're not in the family space. This is a big ward where there are multiple kind of, you know, it's not like they're doing anything there in privacy. These are big rooms with beds. They're positioned several feet away. There's also a very comprehensive informed consent process that everyone goes through. They're well described. And there's also safeguards in that informed consent process, and, you know, usually erring on the side of caution, you know, if there's signs of distress or, you know, the mother, like, don't even immediately don't enroll this person. And, you know, if you want some privacy, we explain all of that type of stuff. So
you get the consent before they give birth?
I'm not sure what this was done after post-birth consent. So for this one, but yeah. So I will defer to Tracy Morris, who was involved in the study, who was nodding along on these things. So yeah.
We also used female observers as well within the postnatal ward. So there were like Kondwani Luwe, that I mean, often here would get involved in the interviews and things with the guardians, but in terms of the ward, there were only female data collectors that we used in it.
Yeah. Okay, thank you so much for your presentations. We still have a few more minutes. Yeah, a few more minutes for more questions and just open discussions. So for colleagues that had questions before, for our previous presenters, if you could just recap on that.
Yeah, I have a question.
Yeah.
Forget your name. David, yes, David. I was wondering, first of all, I don't think you spoke about the actual cost of the potassium permanganate and its availability on the market. Just if you could say a word about what it costs someone. But secondly, along those lines, have you ever considered the very low cost of chlorine using salt through electrolysis, which is very, very low cost, and I think in many cases is actually more cost effective than permanganate.
I'm very happy you're asking that question. So the cost of potassium permanganate is like 50 pesewas, which is 1/20th of a pound per day, approximately. When we ask them about willingness to pay, they say 50 pesewas, 1 CD, 2 CDs, 8 CD, and many people went as high as 5 CDs, which is a quarter of a pound. We did consider chlorine because that's already widely available, but Ghanaians have a big taboo around using non-edible substances with food. So that's why they use salt. If not salt, it's going to be vinegar or lemon juice. And if it smells like chlorine, it's just going to be no way to use that in food. So that's why we focused on potassium permanganate, which used to be widely available like a few decades ago. It's more difficult to find now, even though it's easily available in the neighboring countries. So we thought either we fight the taboo or we try to explore something that we can just resupply.
Yeah, thank you so much for that response. I think I'll have like one last question to all our presenters. So based on your experience and the work that you've been doing, like what are some of the common misconceptions that you had identified during your fieldwork? And like how would you say we can debunk some of those misconceptions?
I would not say it's misconception. It's just not intervention is not in the proper intervention. In many cases, we do education, like training, more training and more training, more, you know. But then people know that that behavior is not correct or is wrong, but they just don't want to change it. And then the motivation is not high enough to change, or is not strong enough to change. There should be something that very, very important for them to change. In our case, for baby faces, is the health of the children. It's always the highest motivation of the mother or the family. Whatever it takes, whatever makes the children grow healthy is the main purpose. They change their behavior. So that's why the approach to them is mostly how to convince them that the children can live better when they change certain behavior. So that's the thing. I don't know. It's a misconception, but kind of not doing intervention in the correct way, or probably targeting the behavior. Thank you.
Thank you. Would you guys like to add anything?
One thing that I noticed on this behavior is that in Ghana, the behavior implemented by the authority is to wash the lettuce under running water, which is something they took from the CDC, which seemed to be a good idea at the time. And the CDC also says that they should keep the lettuce, should not keep the lettuce outside the fridge more than 2 hours. In Ghana, if people have a fridge, they are definitely not going to use it for lettuce. And people don't want to use running water because it's a waste and because the price of water increased by 300%. So the fact that they are recommending something that is absolutely not applicable is something that needs to be taken into account. That sometimes we need to think not from the engineers or funders' point of view, and really from the users' point of view, and they should be involved.
Thank you. Yeah, just a quick point on the scoping review is that we identified 13 studies with a behavior change intervention, sanitation and hygiene practices in urban settings, but this is to say that this is what has been measured, and there have been many more interventions that have been implemented, just a limited number of studies that we found.
Yeah, I think you know the entire kind of health system that we see in a lot of low and middle income countries, where we see hard to get across how one study links to another, but if you can see the conditions that are in these guardian waiting shelters, it really start understanding the even more barriers they're facing at the healthcare facility, and probably more putting the limits on what we can actually address from a behavior change perspective. And what we need to start looking at is things like health systems perspective or urban utility perspectives, and kind of making sure that behavior change is part of these much larger, much more comprehensive programs to really improve WASH outcomes.
Thank you so much for those responses. And I think I've learned a lot from this session today. Yeah, to our presenters, thank you. If you could just stay behind for a group photo. And to our attendees, thank you so much for engaging us in this session. And I hope that you all learned a new thing or two in the presentations. And yeah, I look forward to bumping into some of you and yeah, engaging further beyond this session. Thank you.
I'm sorry about the slides. I'm so sorry.
Can we grab a photo before you just go?
Yeah, sure.
Oh, no.
Everyone smile.
I'm so sorry.
Another picture?
Sorry?
I want to take a photo here with you.
Can I have a picture later? Pardon? Can I have a picture?
What's your presentation about?
Also need the GNC. Okay, I'm going to send those photos to you now.
Thank you so much. Oh, I think that went. I'm sorry about the text. Like, oh.